Comprehensive, relevant, and insightful conversations about health and medicine happen here on MedStar Health DocTalk. If you or someone you know has a traditional pacemaker, you may know that the device itself is attached by thin, flexible, insulated wires called leads that are surgically implanted into the heart. The lead's function is to sense and electrically stimulate the heart muscle. For over 60 years, technology has advanced the use of these devices, and they've saved countless lives. They're designed to stay in the body indefinitely. But sometimes the leads have to come out. To learn more about complex extraction of the leads, we turn to cardiac surgeon Dr. Rachel Harrison and cardiac electrophysiologist Dr. Sunjeet Sidhu at MedStar Union Memorial Hospital in Baltimore. I'm your host, Deborah Schindler. Dr. Harrison and Dr. Sidhu, thank you for being here on MedStar Health DocTalk.
Thank you for having us.
Yeah, thank you.
I called the devices pacemakers, but lead extraction could be necessary for an implantable cardioverter defibrillator, or ICD. What is that exactly, and are there other implantable devices with leads?
So the range of cardiac implanted devices generally include either pacemakers, which function to pace the heart, and these are usually placed in patients who have issues with symptomatically slow heart rhythms, or defibrillators in patients who have issues with fast heart rhythms that can cause them to either pass out or it can even be deadly, like in patients who've had prior heart attacks.
So in the simplest form, how would you define pacemakers, or how would you contrast pacemakers versus an ICD?
A pacemaker is implanted for patients with a slow heart rhythm, whereas a defibrillator is planted for patients who are at risk for deadly fast heart rhythms.
Okay. And in either case, they need a device that has leads.
Correct. And so for the vast majority of devices that we put in, they are leaded devices. There are a plethora of new leadless devices, as well as devices that are placed outside of the heart cavity itself. But the vast majority of implanted devices currently are devices with leads.
Help us to understand how the leads are implanted and why might they have to come out?
So the leads are generally implanted through what's called a transvenous approach. And so the way we plant most of the leads is we access the vein, usually what's called the subclavian vein, the vein that drains the blood from the arm back into the heart. We access that vein using a small needle and place a sheath, which is kind of like a straw, through which a lead is placed into the vasculature, into the veins, and floats down into the heart and then positioned in whatever chamber we're looking to place it into.
And when that implantation is happening, that's happening in the EP cath lab, the electrophysiological?
I'd say the majority of leads are placed now currently in the EP lab. They are also placed by the surgeons as well, whether or not someone is placed at the time of cardiac surgery, or if they need what we call epicardial wire that's placed on the surface of the heart rather than on the inside of the heart. So they are placed in both situations, but I'd say the majority of these are placed in the EP lab.
When you're inserting that into the heart, how far does it have to go, that lead?
Well, these leads can range from, 40 centimeters, so a little over a foot, to 65 or even 88 centimeters. So we're talking about 2 to 3 feet. And it really just depends on the patient's size, height, the heart size, and which chamber you're trying to place the wire into.
Do they ever come out accidentally?
So there are things we call lead dislodgements. So these are usually occurring shortly after implant, but a lead that is usually fixated either by sort of an anchoring, sort of grapple hook type fixation mechanism or by a screw-in mechanism, sometimes they fail. And so these leads can fall down or go into a place where they're not intended and have to be removed or fixed.
But how often does that happen?
They can range, but we're talking about a handful of percentage, 1 to 3% at the time.
Okay. And what's the average length of time someone might have one of these devices in their chest?
They can vary quite a bit. So we can see patients who can have devices implanted with what's called congenital heart block, where they have devices implanted as infants or as a young child. But more often, patients who get devices are older, in their 50s, 60s, and 70s, and they've developed heart block or slow heart rhythms as a result of some age-related process or some particular disease process, like a heart attack or some infiltrative disease that affects the heart muscle.
As we're also getting better as medical doctors, cardiologists are getting better at managing patients medically with cardiac conditions. But then the longer these patients live, the higher their chances become of needing implantable devices such as defibrillators. And so the number of patients with defibrillators is going up steadily, and the patients are getting younger as well who need defibrillators. So we're having this growing population of patients with implantable devices.
And now they're smaller, aren't they?
Yeah, I mean, the pacemakers and defibrillators have both gotten smaller in size. And so they can vary from the leadless pacemaker, which is as small as a bullet, in fact, to ICDs, which can be, I'd say, about half the size of a deck of cards. So they can vary in size depending on their intended function and what they can do, but they have gotten considerably smaller than the first implants.
What's the most common reason that people need to have the leads extracted?
The most common reason that people will need their leads extracted is going to be between infection or a problem with the lead. I think they're kind of neck and neck in terms of incidence. The most common urgent reason for a patient to have a lead extraction is going to be infection. And we know that because if we sit on these patients with an infection, that their mortality goes up steadily over time. So it's important to act quickly in a patient with an infection. How you would tell if a patient has an infection is a little bit more difficult to identify. And what that results in is 8 in 10 patients being undertreated for an infection with their device. So it may present, when we implant the devices, they have a patient has an incision usually with where the device is. So you may see it on the surface of the skin. You may see an infection, but sometimes you may not. The incision may be totally healed and they have an infection on the inside in their heart, and it may be undetected.
It wouldn't show up in a blood test?
It could. So whenever someone comes in with a fever and they have a device or any kind of illness and they get blood cultures, if the blood cultures are positive, then we really want to know about that so that we can consider them for lead extraction.
How would you verify that there was an infection? Is there a scan that they can take in addition to the blood test? I mean, what other diagnostics are performed to determine an infection?
Well, the current literature that we have right now is if the patient has a blood culture that is positive, has 2 positive blood cultures and an indwelling device, it is a class 1 indication, which means it's highly recommended to go on and take the device out as a potential source. So that would be our first move in these patients. Beyond that, we can get an echocardiogram, which can look for further infections inside the heart, as well as look for other sources of infection.
How does that start? And do they come in sick when someone has an infection?
So in patients who have infected ICDs or pacemakers, it's also almost akin to think of an infection of the heart itself, something called endocarditis. And particularly when they have bacteria in the blood, they can be quite ill. And it becomes important in that situation to remove the source of infection, in this case, the defibrillator or pacemaker. In terms of how the infection gets there, it's usually due to some bacteria getting into the blood. How bacteria gets in the blood, it could be from a cut, a nick. In fact, even when you brush your teeth, you can actually translocate bacteria transiently into the bloodstream. And once bacteria gets a hold on to either a pacemaker, the defibrillator, the wires, it's hard to clear with antibiotics alone. And so along those same lines, the patients who are at higher risk for device infection are those who either are immunosuppressed because they've had a prior transplant, have diabetes, or are on hemodialysis and their blood is either constantly being taken in and put back into the body, because those are sources where bacteria can get into the blood and then subsequently infect the device.
Are certain devices more prone to infections, or are certain people at greater risk for developing one?
Rule of thumb I use, the larger the device, the more material, the higher the risk of infection. So the defibrillators are higher risk than the pacemakers, and in particular, one type of defibrillator, the CRT defibrillator that has 3 wires rather than just 1 wire, is at the highest risk because there's just more hardware. And in terms of patients who are at high risk, are those that I sort of alluded to earlier, those who are diabetic, have compromised immune systems because they're on immunosuppressives because of a prior transplant, or are dialysis patients.
I did ask if the patients come in sick, but how can patients tell if they have an infection? What other symptoms are there?
one obvious source, or sometimes obvious source, is when they have an infection at the site of the pocket where the pacemaker or defibrillator sits outside of the vasculature but underneath the skin. And there they can have redness, tenderness. There can be actually even drainage at the site, and those can be a little bit more obvious. But often they're not obvious. Often they come in and they're just feeling unwell. They've had a fever. They feel tired. They feel lightheaded or dizzy. I mean, it may be very subtle that it is a device infection rather than some other illness. And that's where it requires, astute clinicians to realize that there's something else going on here.
Could it happen that the device causes the infection in where it's implanted, as you called it, a pocket without the leads being infected? And I mean, I imagine that you're taking it out as a last resort.
Well, we kind of consider the entire system infected because they're all in continuity. And if you think about a biofilm in medicine, we think about, bacteria create a biofilm around hardware. Antibiotics can't penetrate that. And so if you have an infection of your device and then it kind of has a microscopic biofilm that spreads all the way down the lead, even if you have imaging of the heart that says, the leads look fine, clinically we think of them as infected. So unless there's a major reason not to take the leads out, we will do everything we can to get all of that hardware out and kind of clear the patient of any kind of infection that may be hanging on to some foreign material.
Okay, so let me back up. When you suspect that there is an infection, what are the first steps that you guys do as a team to, verify it? Do you monitor it for a little while, medicate it? What are the steps?
Go ahead. So usually when we get a call that there's someone with a pacemaker or ICD and there's concerns for an infection, we're usually already having them obtain a blood culture. So culturing the actual blood to see if there are any bacterium in the blood. Certain bacterium are known to really like sticking on to pacemakers and defibrillators. And when we see those and there's no other clear source for an infection, generally that means the device has to come out. For some more esoteric bacterium, we can do what's called a transesophageal echocardiogram, where we insert an ultrasound probe into the esophagus and can look at the heart muscle, the valves, and also the leads in high detail to see if there are any conglomeration of bacteria, what we call vegetations, on the actual lead itself. But sometimes all you have is a positive blood culture, no other source. And in a bacterium that's particularly prone to sticking onto the blood, like Staph aureus, the device just has to come out.
It's too risky.
Well, and the data shows there's a most recent paper out of Duke that showed that if you just treat these patients with antibiotics who have a positive blood culture and nothing else, about 48% of those patients will die. If you go on and take the hardware out, even though you don't see it, but there's a positive blood culture, we can reduce that mortality to about 16%. So it's still risky to have positive blood cultures, bacteremia. But if you only treat these patients with antibiotics, their mortality rate's really high, which is why we really want to educate not only the patient population, but also our fellow clinicians that it's really important to send these patients to places that can do lead extraction like we have here.
When you talked about they die, I mean, how do they die? Sepsis?
A lot of times patients will come in with positive blood cultures, a fever, and they'll get antibiotics, and then they go home and they come back and they have this long protracted course. Many of these patients have comorbidities.
It's a good question. I mean, in general, for some of these patients that get an infection and are, in this case, undertreated, the concern is that bacterium is still there. And so that they will have repeat admissions, or they may have protracted admissions where they have recurrent bacteria in the blood. And so, sometimes these patients do die of sepsis, or sometimes they die of the consequences of sepsis, like renal failure or end organ failure. The concern is you got to treat the source. And in this case, the source is often the wires or the device itself.
What other reasons are there for the lead extractions?
So these leads are not perfect, right? I kind of explain a lot of my patients that these leads are man-made, and it's a wire. You take a wire and you bend it enough, that wire will break. And the heart beats about 100,000 times a day, and so that means that wire is beating 100,000 times a day, day after day, 365 times a year for years. And so these wires have a predicted failure rate. some of them higher than others. And when they're high enough, there have been wires that have been recalled, 2 big wires of which were recalled in, the early 2000s, and have been a big source of extractions of of wires that need to come out. But as a result, these wires can fail. And so we carefully watch these devices to see signs that a wire might be failing. Because if we put a wire in someone because their heart rate is dangerously slow, we want to know if that wire is about to fail. And so if a wire does fail, the options then become you either put in a new wire or you take out that old wire and put a new one in its place. When you just put in new hardware, like I explained earlier, the more hardware there is, the higher the risk for an infection. The other problems with putting in new hardware without taking out old hardware is that you can't really get an MRI. So a lot of these new wires are now what we call MRI conditional. But when you have an abandoned wire, they're not studied for MRI. So you limit a patient's access to getting MRI of, let's say, their brain if they've had a stroke, or their shoulder if they're having shoulder pain, or their knee, or their spine. And then the other issue is that the more hardware you have in place, the higher the risk for that vein occluding over time, because those wires are sitting in the vein, they're slowing down flow through the vein. When you slow down flow enough, that vein will close off. And so there are many reasons that are not infectious as to why a wire needs to come out. And as a result, whereas if you go back 20 years ago, the main reason for wire removal or lead removal was infection, now the reasons for removal is about equal. In fact, some cohorts actually show that the reason for removal is actually non-infectious about 60% of the time. And so there's definitely non-infection reasons for taking wires out.
What happens when the wire does break? Is that an emergency?
It often depends on the indication why the wire was put in. So in patients who are what we call pacemaker dependent, meaning they are reliant on their pacemaker working, it becomes pretty urgent that they need to come in and have something done. And often you can temporize them with what's called a transvenous temporary pacemaking wire, but it means that they need something done soon, because without that wire, their heart stops beating. In other patients who have wires put in for defibrillators, meaning that they're at risk for a deadly heart rhythm, it's not like they're having a deadly heart rhythm every day. This is a probabilistic event, meaning it could happen 1 month and not happen again for several years. And so for those patients, it becomes a conversation with their doctor about how long they can wait. We can even use what are called wearable cardiac defibrillators that they wear external to their body to protect them while they're waiting for an extraction. So it really depends on the patient and why they had their pacemaker put in the first place. Correct.
The other thing that you may see with lead fractures or lead breakage is in the ICD leads, those are I call them the shocker leads. They're the ones that deliver the shock or defibrillate a patient's heart who has an abnormally high heart rate that can be life-threatening. In those patients, they are not pacemaker dependent a lot of the time, but they may have inappropriate shocks. So it's like almost like an electrical malfunction where the device senses something that's not there and may shock the patient inappropriately. So that's another reason for the patient to come in, maybe not in an emergent situation, but it's something that we want to handle. And what we want to do as extractors and implanters is to take out the defective hardware and put new stuff in rather than just put more hardware in, which is something that is done in this population.
So by the title of this podcast alone, complex lead extraction, that suggests to me that maybe it's more complicated to get them out than it is to put them in.
That's right. So the leads typically, they will sit from the vein into the heart, but sometimes they'll sit on the wall or kind of embed themselves with scar tissue inside the vein, inside the heart. And so it's not simple just to pull it out. It requires certain technology, laser, mechanical tools to kind of cut away at the scar tissue around the lead so that we can then pull it out.
And is this done through the open chest?
No, thankfully we have a set of tools that allows us to go through the vein in the same way that the device is implanted. We go in the same place and we go through the vein down into the heart, following the path of the lead.
Is this something that you guys do together as an electrophysiologist and an open heart surgeon?
Yeah, so we actually have a really unique situation here at MedStar Union where we work together in the operating room. And we take these leads out and we can actually re-implant leads and get the patient totally taken care of in one setting, if possible, if it's not for infection. We do it in the operating room where it's safe and we have all the tools that we need in case something doesn't go as planned.
What could go wrong? What are the risks and challenges?
The primary concern is vascular injury because these leads are going through major blood vessels into the heart. And so if we have a problem like that, then we need to be able to open the patient's chest and fix that. That's rare. That's very rare. Less than 1% of the time does that happen. But it's important to be prepared in that situation.
I'll say as a electrophysiologist, these procedures and many other sites throughout the country are performed either by the cardiac surgeon or by the electrophysiologist. And as an electrophysiologist who implants and can extract, and having done this at other centers before, it's always nervous when you'll say to the staff, we're going on lead, or we'll tell the staff that we're going on sheath, and we're trying to pull the lead out. And they're calling the cardiac surgeon, because if there is an emergency, that cardiac surgeon needs to be there in minutes, not 30 minutes, not an hour. They need to be in the OR immediately, because when an emergency happens, it is truly an emergency. The longer it takes to fix a tear in the vasculature, the increased risk of mortality. And so the benefit of our program, and the truly unique part of our program, is that we're both at the field the entire case until from start to finish, we are doing the case together. And so I think that's a big benefit to our program in terms of our ability to extract leads and also deal with the complications if they occur.
Because it's a full cardiac center here at MedStar Union Memorial Hospital. Dr. Harrison, you made it very clear that it's very rare for that to happen. And we want to emphasize that it's very rare. But why is it such an emergency? What can happen? Help me understand what could happen. What would go wrong that would require you to need
immediate blood loss. Immediate blood loss would happen. So the patient would bleed into their chest.
So you have to put them on a heart-lung machine? I mean,
sometimes.
Okay.
Yeah. And so, we talk about this like we know what we're talking about on this front, but it doesn't happen that often.
Okay.
Like I said before, it's less than 1%.
Has that ever happened between the two of you?
Not with us. Yeah. But I have seen it.
Knock wood.
Knock on wood. It has not happened to me.
But, and we actually in the last 10 years have developed more tools to help us in that setting. So some of the medical community might think of lead extraction as high risk, but actually we've reduced the mortality rate of a bleed. So let's say a bleed in the operating room during a lead extraction happens less than 1% of the time. So let's just talk about that, less than 1%. In the past, if that would happen, the mortality rate was about 92%. But now we have a balloon that we can deploy that covers up the tear. It's called a bridge balloon. It bridges us to getting into the chest. And that has reduced that mortality rate from 92 to 50%. So we've really cut down on the risk of this procedure just by using the tools at our disposal.
Are you actually cutting it out of the heart? You made the point that you're not pulling it out. I'm just wondering, how do you actually get it out? And
there is some traction.
Are you able to see it? View it?
With both implantation and extraction, we use X-ray to visualize things rather than direct visualization. We're using X-ray to visualize the leads, how the lead is interacting with the heart. And in a sense, we are cutting it out. So the body will form essentially a scar, kind of like a scab around the wire. And so we are cutting through that scar tissue, either physically cutting with a mechanical cutting tool that has little burrs at the end of it, or using a laser to essentially burn through the scar tissue in front of us to take that wire out, because that scar tissue sort of grows into the lead and fixates it in place. And so our goal is to remove that scar tissue so we can get that wire out.
I assume that the longer the patient has had it in, the higher the risks are.
Yeah, absolutely. So the longer the wire has been in, the higher the risk. And there are certain leads that are at higher risk leads as well. And in particular, the ICD leads are higher risk too, because they're larger diameter. They have a shocking coil, which is a coil of wire in which tissue can ingrow. And so there are things that put patients at high risk, or leads that are higher at risk to remove than other leads.
Between the two of us, we have a lot of experience with knowing which type leads are easier, which are more difficult, which are coated in silicone versus the dual coil leads, different types of lead. There's a ton of different types of wires. We talk about wires in the heart. There's a ton of different types. And so knowing which ones are going to be easy and difficult and setting our team up for success to take them out is what kind of sets us apart, I think, as an extraction program.
So it's not enough to just go to a cardiac center. You really want to go to someone who's had a lot of experience, like any medical procedure.
Yes, because it can become very complex.
How long does the procedure take once the patient is, I guess, sedated?
It depends. It depends on a lot of factors. It depends on the patient's own, scarring, how much a patient develops scar, how old the leads are, what types of leads they are, whether or not there's an infection, and how many leads there are. So if it's just one simple lead that was placed a year ago, that procedure may take 45 minutes, whereas it can take up to 3 or 4 hours to get everything out.
And more often than not, would you say that you are replacing the problem leads with new leads?
Yeah, so often the reason the patient had the device put in the first place is still there. So when you take out the hardware, they usually need something back in. It is rare to have a case where you take something out and they don't really need anything put back in. In terms of when you can reimplant, in cases where it's a malfunctioning wire, you can reimplant right away in that same procedure. In cases where there's an infection, generally you have to wait. That means that sometimes patients are waiting in the hospital with a temporary pacing wire if they're pacemaker dependent. Sometimes it means that the patient can go home with one of those life vests if it's with a defibrillator. And in terms of time for reimplant, I think the earliest that we would do a reimplant is somewhere in the order of 48 to 72 hours. We want to make sure that the bacterium is really cleared from the blood before we reimplant a device. But sometimes it can be longer, and it really depends on the patient.
How is a patient protected between the removal of the infected device and the implantation of the new one? Are you monitoring them? Are they coming in frequently? I mean, it could be a lengthy time lapse between those two procedures.
In those patients who are pacemaker dependent, they're not leaving the hospital before they get a new device. And so generally, they're in the hospital with a temporary pacing wire sitting in our cardiac surgical ICU until they get a reimplant a few days later. In patients who have a defibrillator that are not dependent, those are the patients who now we can send out with a life vest, with a wearable cardiac defibrillator, and they can get a reimplant, 2 weeks, 4 weeks, 6 weeks, or longer down the line. And they are actively being monitored or being watched by their wearable cardiac defibrillator in the interim. And so although it's not perfect, it is a way to monitor these patients as an outpatient.
I always like to ask doctors what their favorite kinds of cases are. I'm guessing this is not your favorite kind of case, or maybe I'm wrong.
I enjoy it. It's fun. It's some people call it a public service for cardiac surgeons, but because it's not as glamorous as some of the open heart cases that we do, but it really is a skill set and it's more than a public service to me. I really do enjoy taking leads out and helping patients. And the other benefit is we'll see a lot of patients who have really no soft tissue to hide a pacemaker under. So, for me to be on the team and I can add almost not like a plastic surgery piece to it, modify the chest wall so that the device can hide, patient can't detect it. Sometimes we have patients who will kind of play with their device and mess it up. And so we can help those patients too by kind of putting it behind the muscle where they can't get to it.
They're playing with it through their skin?
Yeah, kind of like a nervous type thing.
Okay, feeling it.
Mm-hmm. Yeah, there's a syndrome called Twiddler syndrome where they're literally twisting their device, not on purpose.
Some people do it
malice,
in their sleep.
For me, I enjoy all the procedures that I do, and this is a particularly complex and rewarding procedure. And the other part to this is that not a lot of people are doing it. Right. And of those that are doing it, some are doing it with relatively low volumes and therefore may not be as good at extracting complex leads. And so this is a service that I think needs to be provided to our patients. I mean, if we look at the numbers, nearly 500,000 devices are implanted yearly. And so if you follow these patients out long enough of them will need extractions or lead management, either for infection or failed wires or recalled wires or what have you, that it's a service to the patient that needs to be provided. And so we're glad to be able to provide it at MedStar Union.
Any final thoughts? Anything that you think people should know about complex lead extractions that we haven't covered?
The other thing about being a lead extraction program is we also are very comprehensive with the entire course of the patient. So not only lead extraction, but also reimplantation, upgrades. So let's say a patient who has, let's say they're pacer dependent, but then their ejection fraction dips, or they have other indications for different types of leads. We can add the appropriate leads or extract and add, and make sure we give a comprehensive level of care to the patient. And then we can also manage them long term. So it's kind of like a one-stop shop. They don't have to search around for doctors to do this and then another doctor to do that. And in fact, we may see patients who are pacer dependent who also have other comorbidities where maybe a pacemaker isn't appropriate for them. Maybe they need a leadless pacemaker or a subcutaneous ICD, which is, I call it a shocker, right? But a shocker that can deliver a defibrillator shock without having to put a device inside the body. So we have that comprehensive level of tools at our disposal. And so I think that's really important to point out, having every single step of the way for cardiac implantable devices.
We've been talking with Dr. Rachel Harrison and Dr. Sunjeet Sidhu at MedStar Union Memorial Hospital in Baltimore. Thank you both for sharing your expertise here on MedStar Health DocTalk.
Thanks for having us.
Yeah, thank you.
For more information about lead extractions or for an appointment with a cardiac expert, call 410-554-6727.